Welcome to this explainer. All right, let's talk about the clinical moment every single one of us secretly dreads. Your hand is literally on the doorknob, you're 45 minutes behind, running on fumes and cold coffee, and your patient drops the bomb. Doc, my hair is falling out. It triggers this instant mild panic attack for us, right? Well, today, we are completely curing your clinical dread. Picture your very next shift. This exact patient, a 46-year-old premenopausal woman, is sitting on your exam table. She's got progressive thinning, maybe some mild hirsutism, and she's staring at you, looking for answers. Now, your burnt-out brain might be screaming, please just refer to dermatology, or maybe you reflexively toss some spironolactone at it, or order this massive, super expensive panel of hormone labs, hoping to find a smoking gun. But here's the deal. You need a fast, evidence-based plan that actually works, and you need it without completely derailing your afternoon. Today, we are cracking open the latest New England Journal of Medicine evidence on hair loss in women. We're going to take you from feeling totally overwhelmed by this complaint to being that brilliant senior attending who manages it without even breaking a sweat. Here is your brand new clinical playbook.
Section 1, the Dogma Detox. It's time to relearn the basics.
For years, we tossed around the term androgenic alopecia for women, basically assuming it was just like male balding, driven purely by skyrocketing androgens. But you guys, that old dogma is out. The new reality? The clinical term is now female pattern hair loss. And here is the totally mind-blowing part. Most women with this condition actually have perfectly normal androgens. No clinical excess, no biochemical excess. It is this wildly complex mix of genetics, hormones, and environmental factors. Waning estrogens and altered aromatase enzymes in the scalp play a massive role. So we've got to stop assuming every single thinning hairline is just a PCOS patient in disguise.
And listen, we have to get really comfortable with this. Why? Because the sheer volume of patients experiencing this is staggering. By age 70, a whopping 56% of women of European descent are dealing with female pattern hair loss. Even in their 50s, it's up to 28%. This is not some rare zebra. This is a workhorse condition walking right into your clinic every single day. If you care for aging women, you manage hair loss, period.
So when you actually part your patient's hair, you're looking for one of two classic presentations. You might see the Ludwig pattern, which is this central spreading where the part just keeps getting wider and wider, or you'll see the Olsen pattern, a frontal accentuation, sometimes called the Christmas tree pattern. Notice how the anterior hairline is usually preserved, the follicles are still visibly open, and the hair shafts vary in diameter because they're actively miniaturizing. No inflammation, no bald spots, just diffuse central or frontal thinning. Moving to section 2, the differential, or exactly when you need to pause. What do those red flags actually look like? Well, if you look closely and see a total loss of the follicular ostia, meaning the pores are literally gone and the skin is smooth and shiny, or if you're seeing erythema, scaling, or isolated eyebrow loss, you need to hit the brakes. These are signs of cicatricial or scarring alopecia, like frontal fibrosing alopecia or central centrifugal cicatricial alopecia. If you see these, pause your medical plan and consider doing a 4mm scalp biopsy, or phoning your dermatology colleagues. All right, section 3, what the data actually shows. If we look strictly at what has the FDA stamp of approval for women, it's a super short list, just topical minoxidil. But out in the real world of expert clinical practice, we practically live in the off-label zone. Low-dose oral minoxidil, 5-alpha reductase inhibitors, and anti-androgens are absolutely where the magic happens. The NEJM evidence fully supports reaching for these when topicals fail, or frankly, when your patient flat-out refuses to smear a sticky foam on her head every single night. Let's talk about the absolute rising star here, oral minoxidil. If you're reaching for this off-label, a fantastic evidence-based starting point is an incredibly low dose, just 1.25 milligrams per day, or even less. Remember, this drug was originally an intense blood pressure medication dosed at 10 to 40 milligrams, but down at 1.25 milligrams, it works wonders on the hair follicle with a vastly safer systemic profile. You start low, and you escalate slowly if she tolerates it. And if you or your patient are wondering, is taking this off-label jump really worth it? Randomized trial data is screaming yes. The NEJM highlights that just 1 milligram of oral minoxidil per day was at least as effective as the messy 5% topical solution. That is huge. You are trading a daily hair-ruining topical application that patients notoriously abandon for a tiny, highly effective daily pill. Compliance completely skyrockets. Section 4. In your actual clinic.
nuance, and those tricky gray zones.
Okay, here is how you save yourself a terrible patient review. You absolutely must warn your patients about the shed. When they start minoxidil, whether it's topical or oral, they might experience a transient increase in hair shedding a few weeks in. You've got to reframe this up front. Tell them shedding is actual proof the medicine is working. It's just pushing out the old resting hairs in the telogen phase to make way for vibrant, new, actively growing anagen hairs.
Section 5. The fine print that actually matters.
With low-dose oral minoxidil, you are mainly monitoring for two things. Roughly 15% of women are going to experience hypertrichosis, which is excess body or facial hair, and about 1% will get peripheral edema. Both of these are totally dose-related, usually popping up a few months into treatment. So if she starts sprouting unwanted chin hairs or her ankles get puffy, you just back down on the dose. It's completely manageable, but you have to actively look for it. Crucially, if you decide to prescribe 5-alpha reductase inhibitors like finasteride or dutasteride, which again are highly effective off-label options, you have to look at the patient's age and reproductive plans. If she is of childbearing age, strict, reliable contraception is completely non-negotiable. These medications can feminize a male fetus. But hey, as OBGYNs, managing contraception is literally our bread and butter, so we are uniquely, perfectly positioned to prescribe these therapies safely. Finally, Section 6, your next shift playbook. Here is your game plan, plain and simple. Step 1, part the hair, confirm the clinical pattern is central or frontal without balding, and check for those red flags. If it looks weird or scarred, biopsy it. Step 2, take a targeted history. Screen for clinical hyperandrogenism, like irregular menses or severe acne. That's going to tell you if you need to add an anti-androgen. Step 3, start the engine. Initiate minoxidil, either the 5% topical or that 1.25 milligram low-dose oral. Warn them about the shed, set realistic expectations that regrowth takes months, and escalate safely. You're going to want to screenshot this brilliant algorithm straight from the NEJM. Keep it right in your back pocket. It maps out everything we just talked about, from evaluating the clinical pattern to hyperandrogenism screening, all the way down to medical and adjuvant therapies like laser treatments or PRP if they want to get fancy down the road. It takes the guesswork completely out of the equation. So, I'm going to leave you with this final thought. The next time that 46-year-old patient mentions her thinning hair right as you're reaching for the doorknob, equipped with this evidence-based playbook, understanding the dogma detox, the dosing, and the nuances, are you going to turf her to a 6-month derm waitlist? Or are you going to step up, use your expertise, and treat her? You got this. Thanks for hanging out with me on this explainer, and I'll see you next time.